I finished chapter 15 today. We'll probably finish chapter 15 today. And we might start on chapter 16. Really kind of depending on how long it takes us to get through chapter 15, the rest of chapter 15. Yes. Okay, so what we've talked about so far has, we just pretty much followed the chapter, and we've talked about the exposure factor, the 4 prime exposure factors we talked about. There's 4 prime factors and everything else is a secondary factor, and we're going to talk about a lot of those throughout the semester. So what we've talked about so far is KVP as a prime exposure factor, MA, exposure time, so the two together create mass, and then distance. So the reason we call these prime exposure factors is because that's what we're going to use to control the quantity and quality of the X-ray beam, right? So KVP and mass together primarily, but secondarily we can use distance as well. I'll talk about an instance where we actually had to use distance to affect a change in the exposure to the image receptor. Here in a bit. So those are our prime factors. Everything else is secondary factor, and secondary factors might not always affect directly image receptor exposure, but they certainly can affect the output of the X-ray tube and what the X-ray tube will allow you to use as far as technique goes to make that exposure. So some do affect image receptor exposure directly, some inversely, and some in a way that you can't make an exposure in specific with specific techniques. So that's what we're going to talk about today. So secondary exposure factors. So KVP, just to run back through it, KVP is what we use to control the quality of the X-ray beam. There are other ways that quality is controlled, and we'll talk about some of those here in a bit. But KVP is what we use. Right? You don't change your filtration, you don't change your machine phase or anything like that. You use KVP to control the quality of the X-ray beam. It controls the penetration, and it secondarily controls the quantity, but I don't want you to get locked into that secondarily thing and think that it's insignificant, because it's more significant than any other technical factor. But it changes the imaging characteristics of the X-ray beam, the absorption characteristics of the X-ray beam. So we don't typically use KVP to control quantity. We can, but that's not our primary quantity control. Our primary quantity control is mass. So then we've got MA and time to create mass. Mass is intensity, intensity is quantity. MA specifically controls the heating of the filament, the formation of the space charge, controls how many electrons we have in our thermionic emission. So at the point of exposure, it controls directly the number of photons that we send across the tube and how many X-rays that we create. Direct relationship. With KVP, it's direct and it's exponential. With mass, be it a change in MA or time, then you've got a direct relationship all the way across the board. Changes nothing except for the number of X-rays. If you double your mass, you're going to double the number of X-rays at all energy levels, right? So it just doubles the number of X-ray photons we emit from the tube and doubles the number of photons that strike the image receptor. So that's MA. Time, we don't have mass until we make our exposure, but it is half of mass, right? So when we're on the prep button, the only thing we're getting is MA. We don't have tube current at that point, we just have filament current. When we hit the exposure button, we send the electrons across the tube, then we have mass, but not before. We don't have MA, right? So we just have heating of the filament until we press exposure, and then the electrons jump across the tube and we create mass. So proportionality at MA is it's half a mass. So regardless of what our MA is, we multiply it times the time in seconds, we create mass. We can use reciprocity to increase MA and maintain, increase MA, decrease time, maintain the same mass, right? So we've talked about when we would use that. If we wanted a breathing technique, we would reduce, and we had a perfect technique mass-wise, then we would reduce MA and increase time. If we wanted to limit motion artifact, if we had a patient who couldn't be still, and some pathologies will cause a patient to move all the time, like Parkinson's has a tendency, patients with Parkinson's have a tendency to have tremors and they shake. So the shorter your exposure time can be, the less motion artifacts you're going to have on the image receptor. Kids, can't really call that a pathology that, unless you've got a really bad kid, but kids just, they're going to move, right? So you want to utilize as short an exposure time as possible whenever you're doing pediatric patients, and especially infants and toddlers. So mass, again, just controls the numbers of photons we emit. And then we talked about distance, and distance, a few things to remember about distance. One is that if you change your distance, in order for there to be a change in the tube current, and that is the mass or the intensity, something else has to change, right? So you're doing a portable chest x-ray on a patient, you set a technique, you back up to 72 inches, you shot your original 40 inches, you back up to 72 inches. What's gonna happen is that if you don't change the technique, what you're gonna have is a reduction of photons striking the image receptor. I wrapped up on Friday with kind of a combination of two things, all right? So that behaves according to the inverse square law. The inverse square law says that as you increase your distance, in this case SID, the source of electromagnetic radiation, if you increase the distance, then the intensity striking the image receptor, now the intensity that is output from the X-ray tube, will drop by a square of the change in the distance, right? So that's why I say inverse square law. You increase distance, the intensity at the image receptor decreases by a square of the change in the distance. So if you double your distance, you go from 40 inches to 80 inches, then the intensity striking the image receptor is going to inverse, increase distance, decrease by a factor of 4, right? All right, so what I did in the wrap up on Friday is I applied to that understanding what we call the direct square law. So when you're reading your test questions, okay, pay attention to what the test questions ask you. If you increase your distance, then what happens to intensity? I didn't say anything about technique. I just said what happens to your intensity at the image receptor as you increase distance. It goes down, right? Okay, most of your questions regarding the inverse square law are going to ask about dose. Okay, so things like you're doing a fluoroscopy case and you're standing 1 foot away from the table, right? And your dose is 1 MR per hour, or plug in milligrade, whatever you want to do. All right, so your dose is this, and you increase your distance to 2 feet, then your dose does what? Decreases by a factor of 4, right? Okay, so most of the time your inverse square law questions are going to have to do with milligray, millirem, something like that. It's X-ray dose. Okay, so the direct square law is technique. Because of that change in distance having a difference, giving you a different intensity at the image receptor, if you want to have the same effect at the image receptor as you increase your distance, you have to do something. Most of the time, we're going to change our mass. So because if we go from 40 to 80 inches, our our intensity drops by a factor of 4, then what do we have to do? Increase. What are we going to increase? I don't mean the hypothetical that I keep saying that I expect that you're going to have to deal with at some point, but right now, you lost photons. So what do you need to add? Mass. Because mass does nothing except for add photons, right? So if you increase from 40 to 80 inches, and this is where we left off on Friday, you need to increase your mass by a factor of 4. Right. So, but we don't use 80 inches most of the time. We use 72 inches, and the cheat code for 72 inches is 3.24. And I always say that you know, when you get to a test question, if 3.24 just doesn't lock in real well, 3.25 will get you as close as you need to be. You're never going to have a test question, even my test questions, where I'm going to give you a calculation for both of those. It's going to be, you know, pick whatever comes closest. You know, if you can only remember 3 1/4, that's fine. 3.25 will get you close enough, and then you just pick whatever technique is closest. The most common mistake that you're going to make on a test question is going the wrong way, and you're applying the wrong law. Okay, so I ask you for dose, and you apply the inverse square law. Right? If I ask you for technique changes, you apply the direct square law. Where most of the time you get off is if I ask you for dose, you apply the direct square law. Okay, now I will give you answers for that. Okay, so don't make that mistake. If I'm asking for dose, what I'm looking for is the inverse square law. If I ask you for technique, I'm looking for the direct square law. Okay, so with technique, increase distance, increase technique. Right? With dose, increase distance, decrease exposure. Right? So don't confuse those. You're probably going to trip, some of y'all, I'm not going to say everybody, but some of y'all are probably going to trip over that all the way through about half of the semester in your sophomore year. Okay? Because it's confusing. But just watch for those things. So what we're going to talk about today is focal spot, machine phase, focal spot, and how that is a secondary exposure factor. So we're going to talk about 3 different types of tubes. We're going to talk about special procedures tubes. When I say diagnostic tubes, you know, they're all diagnostic tubes, but when I say diagnostic tubes, what I'm talking about is general radiography X-ray tubes, what you work with. So we're going to talk about those. We're going to talk about special procedures tubes, and we're also going to talk about mammo tubes. Just because you know, the registry may pick those 3 things. Special procedures tubes and CT tubes are kind of similar in some of their aspects and some of their characteristics. So we don't get into CT tubes, totally different modality, as is special procedures, but for some reason we talk about those. All right, so we talk about dual focus tubes. What we're talking about is an X-ray tube that has 2 focal spots. And most of the time with a dual focus tube, what you've got, remembering this is not a target, but you know, it's a round thing, kind of like a target. So what we've got in a target is not just a flat face like what we're seeing right here, right? What we see in a target is a flat face and then a bevel. All right, so the bevel is just on the edge and the focal track is on that bevel. So what controls our focal spot size is a couple of different things, one being the filament size. And when we're talking about a dual focus tube, that's what we're talking about, are 2 filament sizes. Okay, so you've got 2 overall focal spot sizes. We'll talk about that here in a second. But what controls those focal spot sizes, or what halfway defines it anyway, is the filament size. You have 2 filaments, 1 bevel. You only select 1 filament at a time, so that affects the area of bombardment on the target, and it increases or decreases sharpness of recorded detail depending on what size of filament you use. Okay, so the small filament, we talked about this in the last section, small filament we use that to affect a change in sharpness of recorded detail. The smaller the filament, the better the sharpness of recorded detail, right? So you're shooting hands, what you're going to want to do, because you want to see the trabecular markings in the fingers and whatnot, you want to select small focal spot. So you push the button that says hand and it's going to select that, most likely. So how you can tell that when you get into clinicals, just kind of go, shop around different anatomical parts on your control panel, and you can see what size filament it is giving you for each exam type. So you push the button for abdomen, and what it's going to give you is large focal spot. And how you identify the focal spot is, let's say, this is a button, all right? But, of course, the button's only 1 inch by 1 inch. So if you're looking at a large focal spot, then what you're going to see is colored in, or at least a square inside of that button that almost takes up the entire button, okay? So that's large focal spot. Small focal spot's going to be a small square in it, all right? So that's an indication of what your focal spot is. So you select a KUB, and what it's going to automatically default to is large focal spot. The reason for that is because when we rotor up, we create thermionic emissions. The main thing that'll destroy X-ray tube is heat. We've kind of done that to death. So the main thing that's going to destroy the X-ray tube is heat. But if you take and you select a mass value and a large number of electrons on a small area versus a large area, then what you're going to have is a concentration of heat that's going to burn this little guy out a whole lot faster than this one, right? So high exposure, most of the time, higher exposure for KUB than what you're going to utilize for hands, right? So we can use a small focal spot on small anatomy like hands, or even, let's say, pediatric chest x-rays or something like that, some sort of a very small anatomy that's going to utilize a very small exposure. But when you get up to things like KUB, L-spine, especially lateral L-spine, things like that, you need a larger source of electrons. The downside there is that you're going to lose some sharpness for recorded detail. We talked about that in the last section and last semester as well. Because of the way that the electrons come off of the anode, you're going to lose some sharpness for recorded detail. We have words for loss of sharpness of recorded detail and good sharpness for recorded detail. Umbra means that you've got very good fine lines. Right? And it's a word that we don't use quite as much, but the other word means loss of sharpness for recorded detail and fuzziness on the sides. You remember what that word was? Penumbra, exactly. So penumbra, bad, umbra, good, right? So that was a long walk to say this. What kind of penumbra are we going to have between large and small focal spot size? Which one's going to give us better umbra? Small, right? So large focal spot, we get more penumbra, but we're going to be using large focal spot on anatomy that we're not looking for things like trabecular markings, KUB, lateral L-spine, things like that. Even chest x-ray, we're not looking for that fine detail. So it's okay to lose a little bit of sharpness for recorded detail. Right? So dual focus tubes, what controls really the size of the focal spot is not just the size of the filament, that's what we use to select, but also the angle of the bevel on the anode. If it's very steep, very vertical, then what we get is a very sharp, a lack of penumbra or loss of penumbra. We get a sharper image. If it's very shallow, then what we get is loss of sharpness for recorded detail. So we'll take a look at that later in the semester. So special procedures tubes, because what we're looking for in special procedures is small anatomy, then the size of our focal spots are naturally going to be smaller than what they would be in our general diagnostic tubes. and that's what you call fractional focal spot. The reason we use the smaller focal spot is because traditionally in special procedures, we would utilize a technique that's called magnification radiography, or word to take down, macro radiography. And what we got with macro radiography, or what we were trying to accomplish, was because we couldn't digitally magnify the image, what we had to do was we had to use an increase in OID to give us a magnified image. We wanted the magnification. And we still utilize that now, but it's for convenience more so than anything else, and I'll explain that in a minute. Because we can digitally magnify an image now, it's less important to have that increase in OID to give us that magnification. So macro radiography, what we get with macro radiography is an intentional increase in OID. So what we've been teaching y'all for a little over a semester is that if you increase OID, what do you get? You go from here to here. What do you get? Magnification, right? With the magnification though, what else do you get that you don't want? An increase in the bad one? Penumbra, right? So you bring it out far enough and you see my hand getting fuzzy, right? So how do we overcome an increase in OID? What do we use? Increase SID, right? So we back up to 72 inches when we do a chest x-ray, because you can't put the heart right up next to the image receptor. You back up to 72 inches when you're doing a lateral C-spine, because you have a natural increase in OID. So you back up to 72 inches. But if you want the magnification, would you increase your SID to overcome the increase in OID? The answer is no. So the only way that you can reintroduce that sharpness or recorded detail is with a smaller focal spot size. Okay? So macro radiography or magnification radiography is an increase in OID without an increase in SID, but you're going to lose so much sharpness or recorded detail that you need a special x-ray tube with a smaller focal spot size to overcome some of that. Is that going to make sense? So lock into this. We're talking about two different things when we're talking about increases in OID and changes in SID. If we want to reduce the magnification, we have to increase our SID, right? But if we want the magnification, then we're going to have an increase in OID with no increase in SID, and that's macro radiography. And we still use that. If you ever go over to special procedures or see a special procedures exam, what they utilize is kind of a C-arm setup. And most of the time they'll use two. So they've got one C-arm coming in one direction and one C-arm coming in the opposite direction. And what they do is they put the patient dead square in the middle of that C-arm. Okay, so the patient's right in the middle of the C-arm. And it's always been that way, but before, the benefit to putting them right in the middle was that increase in OID without an increase in SID, and you got the magnification. But now, really, that benefit is a little bit marginalized because we can digitally magnify. But if you put the patient dead square in the middle of that C, and you need to see, the doctor's injecting some contrast and they're looking for a small tumor inside the patient's head, and they need to see it in a lateral, do you really want to have to adjust your height and then go from AP to a lateral, or do you just want to swing the C-arm up into a lateral? It's quicker just to swing the C-arm up, right? So we still use that increase in OID, but it doesn't really give us an increase in image size. It's just for, I won't say just for convenience, even though it just said just for convenience, but it's less so for actual magnification, because we can magnify the image digitally. So that's special procedures tube. Mammo tubes utilize what we call microfocus x-ray tube. And the reason that we use microfocus in mammo is because we're looking for not just small anatomy, but tiny anatomy. All right, so you can take your pen and just make a dot on your paper, and that's about the size of the pathology that we're looking for in breast cancer. So whenever we're doing mammo, what we're looking at is just all soft tissue. So it's all adipose tissue with some ducting running through it. And what we're looking for to diagnose cancer are what we refer to as microcalcifications. So, just the word, you can kind of deduce, microcalcifications. So if we're using a large focal spot size and we have a lot of penumbra, it's going to be tough to see those microcalcifications. We need very, very sharp image. So we're going to utilize what we call a microfocus tube. So a large focal spot on a microfocus is going to be as big as the small focal spot on special procedures tube, which is going to be, as small as the smallest focal spot on a diagnostic tube. Very, very small focal spot sizes. Okay. So roll it back up to this. Now, we talked about this in the last section. When you make an exposure, attempt to make an exposure on a small focal spot size, and you're utilizing a high MA, your machine's not going to let you do it, right? It's just going to shut it down. You try to press rotor, and it'll probably beep at you, and if you look, it says tube overload. Okay, so try this in clinicals. Go push the button for a hand X-ray, and then take your MA and roll your MA up to like 600 MA if it'll go up that high. Okay. If it's still on small focal spot, it won't let you even rotor up because you're going to potentially damage the X-ray tube. You put that many electrons on that little bitty focal spot, and it's going to say, no, you're going to cause some damage here. So it won't let you do it. So on your test questions, what you're going to be looking for is, let me say this first. If your machine will let you rotor up on a technique on small focal spot, if it'll let you rotor up on that and make your exposure, let's say you set a technique, it's maybe 60 kVp at 2 mass, all right? And then you leave your technique the same, but you select a large focal spot, and your technique is identical. Should there be any difference in tube output? What controls tube output? What are your prime exposure factors? MA is 1. Time? KVP. Right. So if your KVP, your MA, and your time remain the same whenever you change focal spot size, should the output of the X-ray tube change? No, it should not. Okay. So let's back our way into that. Let's say you set a technique on a large focal spot and it's 70 kVp, or let's say 80 kVp, 400 MA at 1 second exposure. That's a big exposure. That's 400 mass at 80 kVp. It's a pretty big exposure. And you reach over and you push the small focal spot. What are you going to get?
It's going to change it. It's not going to let you do it.
It's not going to let you do it. You're going to get tube overload, right? But let's say now you change your exposure factors. Maybe you realized because it went beep beep and told you couldn't shoot that. You change your exposure factors. You realize you're using 10 times too much mass, right? So you change from 600 MA down, or 400 MA, whatever it was we used as an example. You change that down to 200 MA, okay, at maybe a 1/10 of a second, right? So that would be 2 mass. You make the exposure on a large focal spot and you switch over to small focal spot, should it allow you to make that exposure? It should, right? It should. Okay, so in that way, did focal spot size really affect the output of the X-ray tube? In other words, should the technique change? Should the exposure to the image receptor change between the large and small focal spot? The answer is no. KVP is KVP, mass is mass, and as long as your machine will let you make that exposure, there should be no difference between the two. So on the test questions, generally what I'm what I'm looking for is one of two things. Will the machine let you make that exposure? If you're looking at small focal spot and you're looking at 400 MA, you're out of luck. You're just not going to make that exposure. But if the machine will allow you to make the exposure, should there be a difference between large and small focal spot, in as much as exposure to the image receptor of the patient? The answer is no. KVP equals KVP, MA equals MA, time equals time. So if you get the same KVP in mass to shoot on both large and small focal spot, you should see no difference in the output of the X-ray tube. Okay, does that kind of make sense? Kind of? Yeah, okay. All right, so quality control. Everything that we have in our X-ray machine has to be tested. You know, all of our exposure factors, KVP, MA, time. We'll talk about each one of those individually as the semester goes on. KVP, MA, time, focal spot size, everything has to be tested to make sure that we're getting what we're supposed to be getting out of it, out of the X-ray tube. So in your focal spot sizes, what we've got are stated focal spot sizes, and that comes from the manufacturer. And our variance is kind of some leeway, is what that means. Okay, so our accepted variance means that our focal spot size, even though it's stated to be 1.6 millimeters, it can be 30% larger than that and still be okay. If it gets beyond that, then we got a problem. We may have a failure of the focusing cup, right? The focusing cup doesn't focus things, then all of a sudden your focal spot size is massive. But notice that the smaller the stated focal spot size is, the larger the variance. It's still going to be smaller, but the larger the variance becomes. So if we get below 0.8, then it can still be 50% above larger than the stated focal spot size and still be okay. And still be within regulations. And it's just because it's harder. You make your exposure, you create your space charge, and you try to compress that. And the further you try to compress it, the smaller you try to make it, the harder it is to try to compress it. All right? So think of it kind of like, I don't know, we just came through Christmas, and you know, you're packing your wrapping paper inside of bags to throw it away after, you know, everybody opens their gifts. The more you try to cram in there, the more it tries to push it back out. Right? And it's just kind of an analogy on the fly. So maybe a bad analogy, whatever. But the smaller the stated focal spot, the harder it is for the focusing cup to direct those electrons just to that one little bitty area on the target. And as a result, we got a larger variance the smaller the stated focal spot size is. Smaller the filament, the larger the variance. Okay? So focal spot, we talked about that. Small filament, small anatomy. That's when we're looking at detail. Thin anatomy, where we're going to have limited exposure. Larger focal spot, we've got, where detail's not as important, where we need high exposure. The X-ray tube can take a higher heat load. Is where we use larger focal spot size. So effects on the image receptor exposure should be none, and I say should be. You know, if you make an exposure on a small focal spot and make an exposure on a larger focal spot, if you just want to go do some experimentation and you look at the output, most of your machines will have an output, dose rate, for exposure. So you make two different exposures, one on small focal spot and one on large focal spot. They come out a little bit different. It should not do that, okay? I'm not saying it's always going to be calibrated perfectly, but it should not do that. So effects on penetration, none. That's all KVP and mass. All right, everybody okay with focal spot size? Focal spots as a secondary exposure factor. And we're going to talk about, we're going to get deeper into focal spot and sharpness of recorded detail later in the semester. So, filtration. remember we've got basically two different types of filtration. We have inherent and added filtration. We've got compensating filters. So inherent filtration, different textbooks, I think I touched on this last semester, if not in the last section. But different textbooks may draw different lines on what it constitutes inherent filtration. What we're going to call inherent filtration is what you have to legally make an x-ray and expose a patient with it, okay? So what that is on your diagnostic tubes, which is all you're going to be working with, is if you make it, if your machine is capable of producing 70 kVp, then you need a minimum filtration of 2.5 millimeters of aluminum equivalent, right? And that equivalent is kind of the key word there, because your x-ray beam is going to have to go through a lot of stuff before it gets to the patient. It's going to have to go through the tube housing, the envelope, right? That's going to absorb some x-rays, and it's going to go through the cooling oil, and that's going to absorb some x-rays, and it's going to go through the port in the housing, that's going to absorb some x-rays. It's going to go through the back of the mirror, and that's going to absorb some x-rays. So if all of that brings us up to the equivalent amount of filtration of 2.5 millimeters of aluminum, we don't have to have anything else. But if it doesn't, then we have to add more aluminum, right? But that's still inherent filtration, because we can't expose human tissue with anything less than 2.5 millimeters of aluminum, okay? All inherent filtration. You can't remove any of that and legally make an x-ray, okay? Everybody okay with that? Anything that you have to add to get to that 2.5 millimeters of aluminum, we're still gonna call inherent filtration, okay? It's anything above that becomes added filtration. So, I've never worked in a pediatric hospital, but I can see in a pediatric hospital where they might use higher levels of filtration. What was filtration originally utilized for? We talked about that last semester. What was the purpose for filtration? Get rid of the lower energy X-ray photons. They're not going to make it through the patient anyway, right? So they just add the patient dose, and they're useless. Remember that we have to have that penetration through the patient in order to make an X-ray image. And any photon that just absorbs inside of the patient never has any chance of getting through the patient. For that purpose, is useless, right? So we put filtration in to get rid of those low energy photons. So I could see where in a pediatric hospital they may increase the amount of filtration that they use to get rid of more of those low energy photons, to get rid of more of the photons that just aren't going to make it to the patient. I can see that. Mammo tubes are going to use all different kinds of filtration to make the beam more homogeneous, remove some of the photons just going to absorb inside the patient's body. Okay? So anything above that 2.5 is added filtration. Where we used to see that a lot is in compensating filters, because the computer algorithm, we didn't have the computer algorithm to even out the tissue density differences on the image. What we had to use was a compensating filter that would compensate for tissue density differences. And where we would use those, and you've never seen these images, so you got to kind of try to imagine it. If we made an x-ray, let's say of somebody's T-spine, all right, so y'all be gentle, all right? Where am I thicker? Top of the T-spine or bottom of the T-spine? Bottom, quite a bit, all right? So what we would do, to get a good APT spine is we would use a compensating filter as a big, thick chunk of aluminum, put the thick end at the top and the thin end at the bottom. So what that did is, and this is something that went into the collimator housing, is slid it into this slot on the collimator housing, so that the thick end was over the neck and the thin end was over the stomach, the lower portion of the T-spine. and that would change the output between the top and the bottom so that I have fewer X-ray photons penetrating through that filter. Numbers, right? We'll get into that here in a second. I have fewer numbers penetrating through the top of that filter than what I did through the bottom, and as a result, it evened out the tissue density differences on the image. Don't really need that anymore because computer algorithm just magically takes care of that. Where you might see something similar to a compensating filter, it's not really compensating for anything. It's more like it's radiation protection, is if you happen to be working in a clinic where they do scoliosis series. They'll use what they call a trough filter. And a trough filter is kind of like two small wedge filters where the skinny ends are pointing in, okay? So to diagnose scoliosis, we basically do I won't say it's a bodygram, but it's pretty close to it. We're trying to get from the neck all the way down to the tailbone, right? And it's usually on young women, so we've got developing breast tissue, and we want to limit the dose to that. So most of the time on your mammography, your scoliosis series, we'll shoot PA, and the body becomes a filter, but we're also using that trough filter to try to increase the effects of collimation, essentially, right? So collimators do so much, but if we add something to it, then it'll help to absorb what the collimators might not absorb and further reduce the breast tissue dose. So that may be the only place that in your career you might actually see compensating filters. But compensating filters are a type of added filtration, right? So inherent filtration is everything that you have to get up to 2.5 millimeters of aluminum. Now back to inherent filtration for a moment. Does inherent filtration, does it remain the same throughout the tube life, the X-ray tube life? Mm-hmm. And that's no. Because what we get is tanning, we get evaporation of the filament that coats the inside of the X-ray tube. You're going to have a tendency to say, yeah, well, that's added. Well, it's added, but you can't remove it, right? So you can't get inside the X-ray tube and scrape it off, so that becomes inherent filtration. It's added inherent filtration, but it's still inherent filtration. Okay, so filtration increases with the life of the X-ray tube. Now, could our biomed guy come in and could that person determine how much that tanning has increased inherent filtration and pull some of the other filtration out to bring it back down to 2.5? And the answer is yeah, they could. Are they ever going to do that? And the answer is no, they're never going to. So in your in your questions, tanning increases inherent filtration. So increases, use that word instead of added so that you don't kind of confuse those two. It increases inherent filtration. All right, so effects on the image quality, really not. It doesn't really do anything to the image quality. The effects on KVP, none. It increases the average, but if we're talking about PB and KVP peak energy, then it doesn't do anything to the peak energy. It does increase the average energy. Effects on contrast, really none. Again, because your computer algorithm takes care of all that. Effects on beam quality, anytime we get an increase in average, remember we get an increase in quality, but the effects on the image receptor exposure are detrimental. And I don't mean that to mean that it's going to ruin your image. I mean that as filtration goes up, again, think about the T-spine, as filtration goes up, thicker aluminum towards the top, we're going to lose some photons, right? So if we lose photons, the image receptor exposure is going to decrease. So I think I pointed this out, in the last section. Probably in filtration, the thing that I see on tests that people kind of get wrong on the test, answer wrong on the test, is that as KVP goes up, what happens to average? Average goes up. Since average goes up, then exposure goes up. KVP goes up, average goes up, exposure goes up. We go from single phase, 3 phase. average goes up, exposure goes up. So naturally, if average goes up, then exposure goes up, right? No. Whenever we get to filtration, exposure goes down. Okay? So how do we compensate for increased filtration? Well, how do we compensate for loss of photons? Almost always. We lose numbers, we add numbers. So we increase mass, right? So effects on patient dose is going to go down. Just fall back to what you know about filtration and why it is that we implemented filtration, and that is to reduce patient dose. So patient dose is going to go down. Okay, so voltage waveform, again, we've got a number of different things to consider in voltage waveform. You need anything? Spill? No. Okay. So single phase, regardless if it's single phase, full wave or half wave rectified, is still 100% voltage ripple. Three phase, we've got three different levels of voltage ripple. That's two. 6 pulse and 12 pulse, and then we've got high frequencies, and that's going to be less than 1% voltage ripple. So with each one of these, with the exception of single phase, regardless of what single phase it is, we're going to have an increase in average. From single phase half wave to single phase full wave, we're going to have an increase in output. And then we're going to have an increase in output on each one of those as we, 6 pulse, 12 pulse, and high frequency. We're going to have an increase in output. So what that means to the image and really the X-ray beam is increase in output with each one of those, right? But once we get to three phase, we're going to have an increase in average beam energy. Voltage never drops to zero with three phase and high frequency. And what that means is, again, we go back to the test grade analogy. You miss one, I throw it out, and what happens to your average? Goes up, right? So we get rid of all those zeros, and our average increases. So with each one of those, we get an increase in output, but we also get once we get past single phase, we get an increase in average. So the effects on the BRIMS spectrum is we get an increase in numbers, and it pushes it towards a high energy side, right? So how does that affect the beam? We get an increase in output. How does it affect the image? Your index number can change. The appearance of your image is not going to be changed, but your index number will change. So, and that's the end of chapter 15. What we're going to talk about in chapter 16 is technique as it relates to the patient. So we're going to talk about patient factors. We're going to talk about image quality factors and adjusting the technique for those patient factors, including and where we're going to spend really the rest of the semester is or a lot of the rest of the semester is picking apart each one of those things. For a column over there. So any questions on chapter 15? You got everything you need in Canvas, notes and whatnot, stuff like that.
Well, this one's up there, right?
It should be, yeah. I think I've gone through this. I haven't reloaded this in, but I've gone through this, and where there's reference to density, I've removed that, or I've tried to remove it. Just know that density equals exposure. When we're talking about density, when we're talking about radiographic density, nothing really affects the density, so to speak, anymore, except for the computer algorithm. So the technique doesn't really affect it, KVP or mass. Index number, yes, but the actual density, not so much anymore. So if you see density, then just make that mental note that it's just image receptor exposure. Okay.
Another one.
Yep.
On focal spot, whenever you're saying like KVP is KVP, mass is mass, and you're changing the focal spot, you were saying that just it makes it remain the same.
Yeah, you're
Technical wise or image wise?
both.
Both.
Both. The only thing that it should change is sharpness of recorded detail, and that's all.
Okay.
So index number should remain the same. The appearance of the image should be identical. The exposure to the patient should be identical, as long as your machine allows you to make that exposure on.
So you were saying like if that exposure is in between and it can do large and it can do small,
Mhm.
that's like what you were saying.
Yeah.
Okay.
Yep.
That makes sense.
Yep.
So the takeaway from that is that the primary factors are only gonna affect the output
Correct. Yeah.
versus the vocal.
Yeah. So I'm not going to expand on that and just confuse matters. Yes, the exposure factors, primary exposure factors, are the things that affect output. Filtration and voltage waveform are secondary that do affect output, but you don't change those, right? You don't change filtration. Your machine. You don't have an option to select the other stuff. As a result, that's secondary. So I said I wasn't going to do that, and then I did it anyway. All right. Anything else? All right. So we'll pick up there on Friday.